All right, let's dive into one of the absolute cornerstones of neurology, figuring out the difference between an upper and a lower motor neuron lesion. We're going to crack this code together.
So, have you ever stopped to wonder how nerve damage can make one person's muscles incredibly stiff and tight, while someone else's become totally limp and floppy? It sounds kind of backward, right? But the answer is actually pretty straightforward. It all comes down to where the damage happens along the body's chain of command.
And to really get a grip on this, let's use a simple analogy. Just think of our entire motor system like a military operation, with a command chain that runs from a central headquarters all the way down to the troops on the front lines.
Okay, so let's meet the two key players in this whole operation. First, you've got the upper motor neuron, the UMN. This is our general up at headquarters in the brain. The general plans the big picture strategy and sends these complex, fine-tuned orders down the spinal cord. And then you have the lower motor neuron, the LMN. This is our sergeant out in the field. The sergeant gets the final order and delivers it straight to the muscle. So the general plans, the sergeant executes. Simple as that. So, what happens when there's a problem at headquarters? Let's take a look at our first scenario. What happens when the communication from the general breaks down?
When the UMN is damaged, you get this almost chaotic state of overactivity. As you can see here, muscle tone skyrockets, which causes that stiffness we call spasticity. The reflexes go into overdrive. That's hyperreflexia. But what's really interesting is that the muscle itself doesn't shrink away, at least not at first. Why? Because it's still connected, it's still firing, it's just completely out of control.
And here's the absolute key to understanding why. The sergeant, our LMN, is still wired up to the muscle, but it has lost that constant calming inhibitory signal from the general up in the brain. See, a huge part of the UMN's job is to refine and basically dampen down our reflexes. Without that top-down control, the local reflex circuit is just left to its own devices, and it goes completely wild. And that's where you get that signature stiffness and those crazy, exaggerated reflexes.
A classic telltale clue for this is something called the Babinski sign. Normally, if you stroke the bottom of an adult's foot, their toes curl down. But with a UMN lesion, that primitive reflex is unleashed, and the big toe shoots upwards instead. It's a dead giveaway that the general's moderating influence just isn't getting through.
So what kinds of things cause this damage at each cue? Well, we're talking about things like a stroke that hits the brain's motor area, a disease like multiple sclerosis that scars up those pathways, or some kind of physical trauma that literally compresses the spinal cord and cuts that communication line from the top. Okay, so we've seen what happens when the problem's at the top, but what if the issue is with our sergeant on the ground? Let's dive into our second scenario, when the lower motor neuron itself is damaged. The logic here is, well, it's a lot more direct. If the sergeant is taken out of action, or the wire going to the muscle gets cut, the final order just never arrives. That's it. The muscle gets zero stimulation. It is completely, utterly cut off from the entire command structure. And a classic sign you see as this is happening is something called fasciculations. As that damaged LMN starts to die, it gets really unstable and starts firing off these random, spontaneous little signals. You can actually see them as tiny little twitches and ripples under the skin. It's kind of like a flickering light bulb. It's the nerve's last gasp before it goes silent for good. The pattern of weakness is another huge clue. A UMN lesion that causes this widespread weakness in a really predictable pattern, affecting big groups of muscles. But an LMN lesion, it's super specific. The weakness is locked down only to the muscles that one single damaged nerve, our poor sergeant, was in charge of. And the causes really reflect this localized damage. We're talking about stuff like a pinched nerve from a slipped disc, a direct injury to a nerve in your arm or leg, or diseases like polio that specifically target the cell bodies of our sergeants, right where they live in the spinal cord. All right, now that we've seen both sides of the coin, let's pull all this together into a practical field guide so you can read these signs like a pro. So, when you're thinking, problem at headquarters, here's your UMN checklist. You're on a lookout for spastic, tight muscles. You're checking for those overactive, jumpy reflexes. You're definitely testing for a Babinski sign. These are all signs of that runaway, unchecked activity. And on the flip side, here's your LMN checklist. Now you're looking for floppy, limp muscles. You're looking for that severe, rapid muscle wasting, or atrophy. You're trying to spot those little fasciculations. And of course, you're testing for lost or absent reflexes. All of these are signs of disconnection and decay. Okay, Quick pop quiz. A patient comes in and they've got a super brisk, overactive knee-jerk reflex. Based on everything we just covered, is the problem higher up with the general or lower down with the sergeant? Think about it. It's got to be higher up. It's an UMN lesion because those calming, inhibitory signals from the top are gone.
Okay, I know. This is a ton of detail to keep straight in your head. So let's just boil this all down to one incredibly simple memory shortcut you can use anywhere, anytime.
Because let's be real, when you're with a patient, you need to be able to recall this stuff instantly. You don't have time to sort through the whole command chain analogy. So how do you cut through the noise and just remember the core difference?
For an upper motor neuron lesion, just remember these 3 words: tight and twitchy.
And for a lower motor neuron lesion, remember the opposite: loose and limp. Tight is for that increased muscle tone, the spasticity. Twitchy covers those overactive reflexes, the hyperreflexia. And on the other side, loose is for that floppy, flaccid tone, and limp reminds you of the paralysis and that severe muscle wasting. Tight and twitchy versus loose and limped. It's really that simple. Look, at the end of the day, the body tells a story through its signs, and being able to tell the difference between UMN and LMN lesions, that's not just some abstract theory. It's about learning to read that story, to pinpoint where a problem is, and to start that whole journey of figuring out what's wrong. So, if you can master this fundamental chapter, just think, what other neurological stories are you now ready to uncover?